2. Camera on. We encourage you to turn on your video. 3. Virtual background. Please use the official background provided. 4. Q&A session. Drop your question in the Zoom chat box using the format name_institution_question. Thank you for the cooperation. Assalamualaikum warahmatullahi wabarakatuh. Salam, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Respectable the Chairwoman of Sekolah Tinggi Ilmu Kesehatan Rajekwesi Bojonegoro, Miss Evita Muslima Isnanda Putri Eskop Nurse MKep, Honorable all of our keynote speaker, 1. Associate Professor Dr. Wan Hanisa Ismail. 2. Miss Wiwi Utami MKes PhD. 3. Sirilu Winichayotin PhD, Registered Nurse. Honorable all the participants of the webinar and the organizing committee. First and foremost, let us offer our highest gratitude to Allah Subhanahu wa Ta'ala for His abundant blessings, mercy, and guidance that allow us together virtually on the blessed day. Secondly, let us extend our salawat and warm greetings upon beloved Prophet Muhammad Sallallahu Alaihi Wasallam, whose noble teaching continuously inspires us toward knowledge and excellence. On behalf of the organizing committee, I extend a heartfelt welcome to everyone joining our international webinar organized by STIKES Rajekwesi Bojonegoro on the theme Beyond the Outbreak, Advancing Interprofessional Healthcare in Infectious Disease Preparedness for Community Dwelling Older Adult. We would like to thank you for everyone the time to attend the webinar today. I'm Tiara Aulia, and it's my honor to serve as Master of Ceremony for today's event. Dear audience and ladies and gentlemen, to commence our program, I kindly request everyone to stand in respect and join together in singing our national anthem, Indonesia Raya, followed by the inspiring March STIKES Rajekwesi Bojonegoro. Dear audience, please stand in respect.
Berprestasi wujudkan masa depan, ciptakan tenaga kesehatan. Berdedikasi lakukan inovasi dan tingkatkan profesi. Semangat maju PKPatria, kobarkan di dalam dada. Jaya alma mater tercinta, berkibar dan sentosa untuk selama-lamanya, untuk selama-lamanya. Mengabdikan ilmu untuk berdiri, berprestasi wujudkan masa depan, ciptakan tenaga kesehatan. Berdedikasi lakukan inovasi dan tingkatkan profesi. Semangat maju PKPatria, kobarkan di dalam dada. Jaya alma mater tercinta, berkibar dan sentosa untuk selama-lamanya, untuk selama-lamanya.
STIKES Rajekwesi Bojonegoro.
Ladies and gentlemen, it is now my privilege to invite the Chairwoman of Sekolah Tinggi Ilmu Kesehatan Rajekwesi Bojonegoro, Miss Evita Muslima Isnanda Putri SKop Nurse MKop, to deliver her opening remarks. Please join me in giving her a warm and respectful welcome. Miss Evita, the stage is yours.
Thank you, Miss Tiara. Okay, test everybody. Can you hear my voice? It's okay? Okay. Thanks for your coming. Miss Tiara is a Master of Ceremony in this seminar. And Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Distinguished keynote speakers, respected moderator, honorable guests, researchers, academicians, healthcare professionals, and all of my students, and our ladies and gentlemen. Before I begin my speech, allow me to share a short poetry greeting. In Indonesia, we can call pantun, but not as usually. I would like to present pantun in English version. Please listening, yes. Beyond the outbreak, hope will rise. With caring hands and vision wise, together we learn, together we grow, creating healthier futures wherever we go. Okay, ladies and gentlemen, it is my great honor and pleasure to welcoming all of you to the International Seminar and Call for Papers 2026. Organized by STIKES Rajekwesi Bojonegoro, East Java, Indonesia. On behalf of STIKES Rajekwesi Bojonegoro, I extend my warmest welcome and deepest appreciation to our keynote speakers. Number one is Mrs. Sri Lulu Winit Chayotin, PhD RN from Mahidol University, Thailand. Good morning, Mrs. Sri Lulu. I'm so sorry if I cannot spell your name well. Yeah. And then our best keynote speakers, number two is Associate Professor Dr. Wan Isma Hanisa Ismail from University Technology Mara, Malaysia. How are you, Dr. Isma? Can you hear me?
Thank you very much, Doctor, for the invitation. today.
Okay.
Are you hear my voice?
Yes, I can hear your voice. Thank you. And then honorable to our respected speaker from STIKES Rajekwesi Bojonegoro, Mrs. Wiwi Utami, MGers PhD. Thank you for accepting our invitation and for sharing your expertise and valuable insight with all participants today. And this year's theme is Beyond the Outbreak, Advancing Interprofessional Healthcare in Infectious Disease Preparedness for Community Dwelling Elder Adult, reflects one of the most important challenges facing global healthcare today. As educators, researchers, and healthcare professionals, we share a common responsibility to generate evidence-based knowledge, strengthen interdisciplinary collaboration, and develop sustainable healthcare solution, particularly for adults living in our communities. At STIKES Rajekwesi Bojonegoro, East Java, Indonesia, we believe the higher education should not only produce competent graduates, but also inspire innovation, foster impactful research, and build meaningful collaboration that contribute to improving pupils' health and well-being. And then in this seminar is more than an academic event, but it is a platform where ideas meet opportunities, research creates impact, and collaboration builds a healthier future for our communities and the world. I sincerely hope that this conference will encourage our productive discussion, inspire innovative research, strengthen international networking, and open new opportunities for future collaboration among our university, researchers, healthcare institution, and policy makers. To all participants, I encourage you to actively engage in every session, exchange ideas openly, establish new friendship, and seize this opportunity to build collaboration that extend far beyond today's conference. Finally, I wish you all, our participants, an enriching, productive, and inspiring conference. My today discussion generate innovative ideas, meaningful partnership, and lasting contribution to the advancement of global healthcare. And from Madi Hall University and from UITM or University Technology Mara Malaysia, I hope that our collaboration can be long-last and to be continue with our meeting in the other session. Thank you for the opportunity to welcoming all of you, and I have a last sentences here to give motivation to all our participants. And as an African proverb beautifully says, if you want to go fast, go alone. If you want to go far, go together. So let us go far together for better science, better collaboration, and better health for all. Thanks you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Miss Evita, for such an inspiring the opening, yeah? Okay, before we continue the main session, I would like to share a few important announcements for all participants. First, all participants are kindly requested to complete the post-test, which is available on your LMS account. Please make sure to submit your answer no later than tomorrow. Lastly, your e-certificate will be available for download through the LMS system after you have fully completed the post-test. Ladies and gentlemen, as we have finished our opening session, to lead next main the webinar agenda, I would like to invite Mr. Agus Ari Afandi, MPSE, to moderate the webinar today. Hello, Mr. Ari, how are you today?
Okay, hello, Tiara, thank you. I'm fine today.
Okay, are you ready to moderate this session, Mr. Ari?
Okay, yes, I will be guide for the next session.
Okay, Mr. Ari, this is your time.
Okay, thank you very much for Tiara Aulia, one of the students from STIKES Rajekwesi, and also for the MC for this seminar. Assalamualaikum warahmatullahi wabarakatuh. Okay. Honorable Mrs. Evita Muslima Isnanda Putri as the Chief of STIKES Rajekwesi Bojonegoro. Honorable, our speakers today. Number one, we have Associate Professor Wan Ismahanisa Ismail, Sirilu Wini Chayotin, PhD, and Bibi Utami, PhD. And all of the participants today, we are very happy that can attend this meeting, although by virtual. I hope that all of us in good condition. STIKES Rajekwesi Bojonegoro, collaboration with the Center of Training and Education Development, PPNI, and to celebrate 32nd Dies Natalis, we are proudly present international webinar by topic Beyond the Outbreak Advancing Interprofessional Healthcare in Infectious Disease Preparedness for Community Dwelling Older Adult. Well, ladies and gentlemen, as the populations continue to age and emerging infectious disease present ongoing global challenges, preparing older adults to remain healthy and resilient within their communities requires more than clinical expertise. It demands strong collaborations among healthcare professionals across disciplines. Today's seminar provides an important opportunity to explore innovative strategies, share evidence-based practice, and strengthen interprofessional partnerships that promote prevention, preparedness, rapid response, and continuity of care for older adults living in the community. We are honored to have distinguished speakers who will share their expertise and inspire meaningful discussion. I encourage everyone to actively engage, exchange ideas, and make the most of this valuable learning experience. With that, let us begin our seminar, and I wish you all an insightful and productive session. Well, guys, I am Agus Aryavandi as moderator today. I will tell you the rule of our webinar today. Anyway, I would like to say thank you very much for all the participants today. It's wonderful time, although we have only meeting in the virtual. Dear all of the participants, here I will tell you the rules of our discussion today. Number one, you may open or close your camera. Which one is comfortable for you? And number two, please off the microphone during the presentation, during the speakers. And number three, I will give time to speakers to have the presentation, 40 minutes, I hope enough for each speaker. And number four, we will have discussion after the speaker finish presenting the material. And five, for participants who want to give question, you may open microphone or maybe you can write in the chat room. Okay, ladies and gentlemen, we can't wait anymore to see the speakers. The first, I would like to give the opportunity for Associate Professor Wan Ismahanisa Ismail from Faculty of Health Science, University Technology, Mara, Malaysia.
Okay. I hear my voice.
Okay. Yes. Yep.
Okay, alhamdulillah.
How are you today, Mrs.
Alhamdulillah.
Wan?
I'm in the mode of traveling. My flight is at 11 to Jakarta actually to participating activity in Jogja and also Bandung for 7 days. Been in Indonesia.
Oh,
So inshallah, thank you very much for Pak Agus for introducing me. Good morning and very warm welcomes to everyone. In my name, Wa Ismahani Sabin Ismail. It's very great honors, okay, and privilege to both of you today. To appreciations goes to the STIKES Rajekwesi. Thank you very much to kind invitations and also the hospitality. I would like also to express the gratitude to chairman, to members, to the students, so also all the participants who present for all our meeting today. A part of this is a part of our collaborations, the new of the collaborations. Okay, today is not only about the sharing. Okay, but our start of our friendships, our collaborations, okay, between Malaysia and Indonesia. Actually, I really love go to Indonesia. I've been the more than 20 university in Indonesia. Actually, I think all the parts of the Indonesia I've been. I think more than 20 of the regions I've been there. So today we are gather under the theme of the beyond of the outbreak. Okay, this very good topic. Okay, because we are the area of the healthcare. Okay, as the workforce of the infectious disease preparedness, we are already been faced the situations the 5 years ago, 6 years ago, 2020. Actually, during that time, 1 month before the breaks, okay, I've been in Indonesia. I've been in the Surabaya during that time. So for the first visits in Indonesia. But we are reminded that preparing the future of our infectious disease because the threat is there. The threat is there. It continuously will happen. Okay, and we are as the healthcare provider are requiring the response of the outbreaks. Okay, this is what we are here today. Okay, because the commitment to develop the resilience of the competence, and all of you will be in the workforce. Okay, to make sure the continuously help maintain. Okay, thank you, and I wish to everyone will be fruitful in the inspiring of the conference today. Who can open my slide? Can I open my own slides? Would I?
Yes, yes, please.
Okay, thank you then. Sorry, many things have been okay. So are you seeing my slides? Boleh nampak slide saya?
Yep, okay.
Okay,
Yes.
thank you very much.
Mm.
So me myself, okay, from University Telana Jumara, UITM, is located in Penang. Everyone dah sampai Pulau Pinang belum?
Never, never.
Oh, you have to go, because I'm the chairman of the conference of the International Community Service Academic Conference on Public Health also. It been in August, will be held in August. So I propose invitations to all of you guys, okay, to join as the who's the chairman? Sorry about the I go the invitations all of you to join the international symposium on public health and community service. So we are going to do many things have in the 3 days. Okay. So leading the future of zoonetics. Okay. I've got my area. Okay. So I need to share about the leading of future zoonotic pandemic preparedness, because it's a building of industry of the healthcare as the workforce, okay, through in one health. Okay, in actually in which area, okay, we have to working together. Okay, like your that mentioned before for the introductions before. So in one help, in one roof, okay, to make sure is our preparing yourself. Okay, so the spillover risk is scaling exponentially. There are increasing known infectious diseases in people can spread from the animal in 6/10. But the new or emerging infectious diseases in people originate from animal 3/4. but 1 billion estimate annual illness from the zooness of the worldwide. 1 billion. Okay, so the potency to get another outbreak is there. So that's why we face the problem is past no I think more than 20 to 30, 50 years, 60 years, 70 years ago. Okay, we are facing about the measles, mumps, it's everything. Okay, but now we are facing 6 years ago, we are facing about the COVID-19. Okay, we now as the healthcare provider, as a healthcare members, we have to prepare. Okay, we have to prepare our own selves. Okay, to make sure another kind of the diseases, okay, we can be ready. We can be ready. Okay. Okay, so that's why the collaborations before the crisis, okay, so I'm already started the collaboration with all over the country. I'm already been done the collaborations with I think more than 15 of the country, including US, Canada, Algeria, Kazakhstan. It's everything because we are afraid we are facing this problem in the future. Okay, because the three out of four new infectious diseases in humans are zoonotic. Because it's jumping from the animal to the peoples. Okay, we have the animal, we have the animals everywhere. Okay, and the peoples. Okay, the connecting. Okay, between the animals to peoples, including like the parasites. Okay, microorganism, viruses. This is called the who are transfer the modes. Okay, between the animals to the peoples. Okay, but who are the people make have to readiness? Okay, the labs persons, the clinics, okay, the field, physiotherapy, nurses, okay, uh, medical lines, okay, it's everyone's. Okay, because the future professional is the interpersonal education in here. Okay, today you are participate the collaboration. Today you are participate of the conference. You know about the importance importance of the collaborations between each of the professionals. Okay, because the preventions must move the upstream. Okay, because we have to plan the target the risk reductions. Okay, to prevent the hospital waiting emergency. Okay, and one more thing, the collaboration must be become the routine of the practice. It's been a year. Okay, we have to start from now and then continuously be happen. Okay, you are cannot work your by your own. Tadi ada your chairman already talk about the if you are do in together in the group, you are being strong. If you are stay in alone, you will be only you. Okay, you cannot be succeed. Okay, so the spoiler of journey why is called One Health. Okay, One Health is considered is our best practice. Okay, because this is what we have to be mentioned. You have to be and bear in your mind. Okay, because the disease come from the animal, human activity, the animal transfer to the human. Okay, and then the breaking to the disease. Okay, but we have not enough time. So the preparedness of ourselves, okay, to make sure, okay, we are ready to face another of the uh, breakout, okay. Okay, the path of the spillover begin upstream because we are start from the land use, okay, biodiversity, because it's one of the ecological pressures out of what the contact patterns, okay. So the agriculture, wildlife, and trades, market, and because the pathogens is circulate in the animals, okay, moving of the parasite, moving of the bacteria, moving of the virus is amongst the animals, okay? The closer contact of the animal and the vector, okay? So the pathogens and the outbreak is begins, okay? The system is consequent, hit simultaneously when they are start from the beginning of the lands, go for the agriculture, and then the closer contacts, and then the pathogen will spill over all the country. Okay, we are experienced kan 6 tahun lepas, you cannot go everywhere, just stay at home. Okay, within if you are going to to buy something, you have to one family only one person. So I can imagine it happen for the future. So we hopefully okay we are ready to prepare for our another breaks. Okay. So because the repeated the failure of the connects is early signs, okay? Because we are failed to recognize the scientific signal. Because for example, the mpox. Mpox happens is the more than 20 to 20, 50 years, okay? It's non-pathogen. We mentioned in the new network and geographics, okay? H5N1. COVID-19, Nipah virus, Ebola. Okay, this is a global connectivity. It turns to local emergency into the systemic crisis. Okay, the systemic crisis happen. Okay, because okay the system are failure to connect in one of the country to another country, one to collaborator to another collaborators. Okay, failure to connect is the early sign the outbreak will be happen in the future. That's why we call it is one health. Okay, it's one health, one community, one professionals. Okay, we are get in satu rumput untuk menyelesaikan for one problem. Okay, because of the disconnecting of the signal. Okay, we are noticed that it's very high. It's very high. Okay, for example, of the COVID-19, the global connectivity, the local of the emergent into the systemic real crisis. Okay, for Nipah outbreak occurred, the localized hard to detect the cluster. Ebola, okay, because it's the use of the deep trust, culture, community engagement, H5N1. It's mpox. It's based on the new geographics of the networks because we are failing to the connecting, failing to connecting to then the outbreaks okay will be uh, happen. Okay, the preparedness buy time to save life and economy. That's why okay the early warning, the rapid of the verifications, the coordinated of the response and continually is we are safe the life and we save the economy. Okay, during the COVID-19, we are face the economy. Ramai yang berhenti kerja, ramai yang tiada pekerjaan, and many people who have to lost their jobs. Okay, so who are the healthcare provider have to working 24 hours, 48 hours, 72 hours because we are not ready. We are not prepared to face the outbreak. But if you are prepared the outbreak, we can save the life. We also can save the economy. We can save the world. This is very important ecosystem. Okay, that's why it's considered one health to make sure we are can save life and economy. As the person in the healthcare provider, of course we have to save the life. Okay, because the economy you can the economic burdens okay make the issue continuous issue, the mental health issue, the problem from family problems, is many things it will be happen. Okay, the under of the one health the paradigms okay require complete of integrations. Okay, because the health tree in one domain rapid become a crisis because in human health, animal health, and environmental health, okay, these three connectings, okay, will be become a crisis. Okay, if in one health, okay, for example, in human health, we have the clinical care, infection prevention lab, diagnostic risk and communication. In animal health, we have the livestock. We keep the livestock. We keep the wildlife surveillance. Okay, wet diagnostic, biosecurity, food production. This is what we are ready preparedness for your own for your own okay for your own country for your own economics. Okay, so the environmental health. Okay, the land use change. Okay, the water, soil, the climate, so vector, and also a part of the control of our ecology, ecosystem. When we say about the breaking of this plane of the sides of the parallel worlds to join, okay, in action, In traditional way, okay, we are separate the surveillance database, delay information, different case definition, reporting the cycle, duplicate laboratory, field investigations, sector-specific budget, and accountability response begin after human case rise. We are not learned from the mistakes, okay? During the Ebola, during the mumps, during the H5N1, we are not ready for the outbreak. But during the COVID-19, is very, very biggest of the outbreaks is happen in all the world, okay? So now we are moving to One Health operating models, okay? We are build the network share risk assessment what we are doing now, okay? What we are already started, okay? The protocol, the simulations and the communications plans from one country to another country, from one university research to another research place, okay? So because the outbreak investigation must be in the team, okay? We save the budget, okay? We control the budget because we are do in the collaboration. Okay, we are do in a part of the networks. Okay, we are investigate in the team. Okay, because we in afterwards. Okay, we can coordinate the financing and also the governance. Okay, to make sure the government understands. Okay, we are have to do this to prevent the case rise. Okay, like the previous times. Okay, because the prevention at the source before the widespread of the spillover, towards the end we can save the life and we can save the economy, we can save the people, we can save the country, and we can save the world. So it's everything is connecting. Okay, it is called the one health in one roof. Okay, we are doing the same goes detect, okay, the problem, we are managed to control. Okay, so what is the innovative, the one health model we are using? This is data flow. Okay, by using the data, we can the interoperable surveillance linking humans, animal vector, and environmental data. When we can save the time and action by the risk assessment and preparation at the ecological sources. The step of the investigations in months of the labs research labs, okay, to join the outbreak investigation teams with the common protocol, with the same goals protocol, okay, then in the end we can coordinate the financing, targeting the upside preventions, and then with the crisis not be happen. Okay, can minimize the problem, okay, will happen. So the mechanism in action interrupt things, tricks, and at the source. Okay, the barrier walls, okay, WOH model, 70% of vaccination acts as a physical barrier, stopping the pathogen at the animal source because it can reducing costly dependent on human post exposure treatment. Okay, we are planned to reduce the treatment exposure. Okay, so by integrating the antimicrobial resistant surveillance, okay, by using the data, okay, in human health, animal or food system, we can manage to target the prevention resources accurately because we are already prepared, okay, the system, the human, okay, who are in the engine, okay, for example, environmental, animal, okay, a human workforce. We are working in the same target, okay. This is what the workforce as readiness in the ultimate of the multi-fields, okay. Human clinic, animal farm, animals, okay, veterinary service, wildlife, water, wastewater. So it's everyone. Everyone are in a coordinate the same action because the response fails when the sector detect separately and act too late. So we cannot face we cannot reduce the deaths of the humans. In One Health and interprofessional education, it turn knowledge into the coordinate of the actions. Okay, this is very, very much important. Okay, we are in the, there looks like this spider web. Okay, we are connecting in each other to make sure the warning signs we can be ready. Okay, we are here to prevent the disease. Okay, to reduce the death, to improve the economic barrier. This is very important parts lah. You have to notice them. Okay, so expanding the core of the competency. Okay, you as a student, we are as a researcher. Okay, as leadership and ethics. Okay, you are the one have to make decisions. Okay, while protecting the equity and trust, the community partnership, communicate risk, counter misinformation, and design the cultural appropriate actions. Okay, because okay, you as the industry ready professional, okay, to be in the future, because the outbreak operations by handling by you. Okay, to detect, investigate, to report, and coordinate the emergency response. You understand, will be happen in the future? Okay, you are ready, mental and physical. Okay, when the emergency is happen. So the interprofessional education, IPEC ecosystem, okay, whatever, okay, students, okay, background program in healthcare, provided as a healthcare provider, for example, environmental health, medical lab science, public health, nursing, medicine, pharmacy, veterinary medicine. This is one who are in the ecosystem, okay, because the field are immersions. Okay, we are drills, we are connecting. Okay, we're solving the cross sector cases, and then we engage the local side, and then afterward we are ready to preparedness when we are faced the another pandemic. Okay, so redefine the point of interventions. Okay, when I go to the environmental and animal health, we are focused to ecosystem, wildlife interface, and agriculture. Okay, because we understand the viruses or another zoonetics. Okay, they are transferred between the animals. Okay, you are the one who needs the foods from the animals. Okay, one health target, the target risk reduction and the source. Okay, by using the vaccinating, 70% those are source can be reduce the exposure of the treatment. Okay, so this is what we are already, I mentioned that before. Okay, this is what, okay, for example, technology as enabler converts by the human insight. Okay, now we are have so many AI, artificial intelligence. Now I'm the another. I'm done my training in the France that before last year for the artificial intelligence for the humans. Okay, we are focused for the okay, oh my god, the memories. Okay, the memories among the geriatric. Okay, we are detects of the called the what is called the this kind of the disease. Okay, they are forgetting. Okay, because the kind of the genetic disease. Okay, by using the AI, we can signal detection early. So we can fit into the human governance, and then we can say the prevents of the disease will be happen in the future. So contohnya kan dementia, yeah, we are working in dementia in AI. So dementia is genetic disease, okay? So then the people who have the dementia around the 45 years, okay, they will be early of the signs, okay? So that we are detect early of the sign of the humans, okay, who are potential to have the dementia. So that they are ready to get is everything the source. Because when it's happened, okay, the example of the dementia, okay, only then when the person have the dementia, baru dia notice that he has the genetic disorder related to dementia. So that's why we're using the technology lah, okay, to prevent any of the future of the genetic of the disease. Okay, this is what genomic translation engine. Okay, we are using the specimen sequence, bioinformatics. Okay, this is what we are done nowadays. Okay, epidemiologic linkage. Okay, the critical step. What we are need to do the metadata. We are pull in the data in one engine. Okay, is everyone to have the action in same action. They call the public health action to use the guiding of the vaccine update, diagnostic, and the border of decisions. Okay, when you are doing the decision, we are use the same of the line. Okay. So, what the artificial intelligence algorithms do and what the human leaders must be governed. AI you are using as you are part because the ultimate or even the base of surveillance detect faint biological signals, okay, forecast, monitor natural language, okay, and media. So now we mumbling of the mouths, okay, we are says that it can recounts, okay, sama ada that person have the facing of the dementia. Okay, prioritize investigation resources of allegations. Okay, that's why we are do in terms of the collaboration. But as human leaders, you as human in the future to be a leaders to make sure ensure the data equity and identify the algorithm bias, interpret false alarms and manage uncertainty, and protect privacy and secure the community consent to ensure the accessibility to local of the population and take the ethical accountability for action. In whatever AI will be producing is every spark in it very high nowadays, okay? But as human, you must govern the and control and the uncertainty of the algorithms, okay? AI. Okay, this is what I have the partnerships of the model. Okay, in One Health, okay, the succeed where the collaboration become the routine practice. Okay, from Malaysia to Indonesia, from researcher to researcher, from student to the students. Okay, do the collaborations as well. Because in one academic, you are as the educator, you as the researcher, and you are the student pipeline to make the industry, technology, diagnostic, and work placement. So you will be in working, okay? The share outcome, job ready graduates and faster the outbreak response. Okay, so then you are ready mental and physicals, okay, to govern and the community to make sure the policy implementation, the surveillance will be successful. Because the in one health success only when the collaboration becomes it's happen lah. Routine practice. Bukan tahun ini, tahun depan tidak ada lagi. Tahun ini kolaborasinya, tahun depan tidak berkawan lagi. I'm always says to my student as well, okay, waktu semester 1 berkawan, semester 2 berkawan, semester 3 berkawan, semester 4, 5, 6 tidak berkawan, bergaduh. So that's not the collaboration become the practice. So this must be continuously happen as the practice. Okay, kerana the successful be happen in when we are winning, succeed, okay, when the collaborations become the routine of the practice. Bukan in one time of the shot, okay, we cannot be success then. Okay, this is what the visions of the new state action plan, the curriculum, assessment, the practice exposure, research and innovation, and the last one is governance, okay? Okay, we I need to prepare, okay, by curriculum, you have to put a part of the important assessments, okay, by OSCE, so the industry placements, okay, research and innovations, okay, develop the student project, okay, whatever related to the problem you have to sort of. So it's because the technology without interpretable the themes is just a faster of a noise. Okay, technology innovation, human collaboration is one task force is very important. Okay, to make sure it is successful. Okay, this is what we are need to facing. Okay, creating interprofessional workforce is stimulation, case-based learning, field immersions, community-based education. This is a part of you are in the way of you workforce. Okay, kita tak boleh buat dalam universiti saja. We have to go to the field. Okay, have to do the learning of the based on the case. Okay, going to the clinical, and then you have to be engaging. Okay, with the local farm, school, lab, environmental science, it's everything to make sure that everyone understand what you want to say and what you are doing now. Okay, this is what the crisis. Okay, this is what the summary. The rising threat why we must move the outstream. Okay, the global crisis. Okay, the lesson from the recent threat. COVID-19, Ebola, 95N1. This is what we are facing. That previous one. Okay, in One Health framework, breaking of the silos. Okay, we are working as a human health, animal health, One Health in working to prevent and building the industry ready of the workforce, and towards the end we action the plan and also for university and also the governance. The train together, stimulate together and respond together, which is the future health workforce must be more than qualified. It must be collaborative, data literate and ready to lead mental and physically before the next zoonotic pandemic arrive. And you are being here. Yes, I've been there. I've been ready physical and mentally. One helps succeed when the collaboration become the routine practice, not an emergency improvisations, because the future workforce must be collaborative, data, laboratory aware, and a community trust. Okay, train together, stimulate together, and respond together, inshallah. Thank you very much for today presentations. Okay. Thank you.
Yep. Yep. Associate Professor Wan Ismanisa Ismail. So I think from your presentation that collaboration must become routine practice, and One Health to say it when daily habit rather than emergency improvisation. Yeah. Build the right ecosystem, we can save the world. So it's very good. Yeah. One Health opportunity model can be innovation to prevent the outbreak. Train together, stimulate together, respond together. Okay.
Yes, working together.
Yeah. Okay. I will give the opportunity for the participants. If you have question, please, you can raise your hand and open your microphone, please. Okay, anyone? The participants? Please, you may open your microphone. Yeah, okay. We have participants to give question for our speaker today, please. Alia Revidia, yeah, you may raise hand. Okay, please, Alia, time for you.
Okay, thank you for the time. Permisi, Prof. Considering Indonesia and Malaysia share similar zoonotic disease risk, while Indonesia still faces challenge in across-sector coordination.
Okay, thank you. Considering the Indonesia and Malaysia share similar zoonotic disease risks, while Indonesia still face challenge in cross-sector coordination, what One Health strategies or best practice from Malaysia do you think would be most relevant in implementation in here, Indonesia? Thank you.
Okay, what we are doing now, okay, so that's why we are considered to do the university part as you as the researcher, okay? You as a researcher, you as a student, then you are going to do the research, okay? As the best practice, okay? So the researcher produce the paper, okay? So we are trying to push the government based on our finding. For so based on our finding, the research of the finding, we getting of the says that this is a very important issue to settle out. Okay, that's why in the way of the university have to do their works. Okay, medical line have to do their works because they have patients. Okay, we as the researcher and then the medical line provide this patients. Okay, so then we are doing the research together. So then we provide the data, we publish the papers because that's why we need to publish the papers. Because if you are not publish the papers, no one knows who you work, your works, right? Okay kan, betul kan Pak Agus kan? Kalau kita tidak publish papernya, siapa tahu kita punya kajian? Okay, kita harus beritahu satu dunia. Okay, Malaysia is happen this data. Okay, this is what we are doing. Macam itulah, insyaAllah. Okay, thank you very much.
Yeah. Okay, thank you. So best practice is based on the research, yeah. So as I think
Yeah.
Malaysia and Indonesia, we closely. It can be that we can
Yes.
join to, yeah.
But, we are
Okay.
same kind of the food actually.
Yeah.
So cultural, same clothes. Bahasa pun sama. Looks like it's similar.
Yeah, yeah, yeah. So it's
Kalau
similar
diberi
with,
pilihan saya ke UK, ke Paris dan before Kazakhstan, I'm happy to go to Indonesia more than the UK, Paris or Kazakhstan. Because we have the same culture, similar of the language, okay? So we are close of the each others. So it's better to do the collaboration. Okay, the start up with the small things. Okay, we continue to see it happen in the future.
okay. So and we also very waiting for the time if you can come to our
Yes,
campus. Yeah. Mhm. Okay, still have question? So, okay, I see the time that, okay. Anyone? I give you, I will count 1 minute. If no question, I will give conclusion from our speaker, the first speaker today. Okay, please, I give time.
If anything, I'm really sorry because I have to catch my flight.
Okay, yeah, okay, yes, I'm sorry.
I have to catch
Yeah.
my flight. Okay,
Yeah.
I'm in boarding time now.
Yep, okay, so,
I'm really sorry.
so thank you for it's wonderful time for Associate Professor Wan Ismail, and let's make documentation before you leave this room. Okay. Okay. Yeah. Okay. And now we will give the certificate to Associate Professor Wan Ismail. Yeah. Yep. Okay. Thank you for our speaker today, Associate Professor
Thank you
Dr.
very
Wan.
much. Inshallah, we continue to happen in the future. Inshallah, we meeting again.
Yep.
Inshallah, thank you very much.
Yep. Okay. You're welcome and keep healthy.
Okay, thank you.
Yeah.
Thank you
Okay.
again. Thank you, everyone. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
I'm
wabarakatuh.
really sorry.
Yep.
I have to catch my flight. Okay, thank you very much. Assalamualaikum.
Yes. Waalaikumsalam. Okay. See you next meeting. Yeah. Okay. Okay. Well, ladies and gentlemen, and all of the participants today, after we had finished a wonderful speaker for the first, and now let's continue to the second speaker today. We have Mrs. Wiwi Utami, PhD. She is from STIKES Rajekwesi, Bojonegoro. Yep. Okay. So, Mrs. Wiwi Utami, PhD, her daily activity as one of the lecturer in STIKES Rajekwesi, Bojonegoro. He had completed the education from Lincoln University College, Malaysia, and also he emphasized the research based on the stunting and other about the child and baby. Okay, please, thank you very much. I will say greeting to our speaker today. Mrs. Wiwi Utami, you join us.
Okay, Mister, I'm ready. Thank you.
You are the second speaker in our international speaker today. And so, ladies and gentlemen, please welcome our second speaker today, Wiwi Utami, PhD, with the topic Innovations in Infection Prevention and Control, Minimizing Healthcare Associated Infections During Crisis. It's your time, please.
Okay, thank you. Good morning, everyone. Good morning, everyone. Okay, thank you for being here today. My name is Wiwi Utami from STIKES Rajekwesi, Bojonegoro. Thank you for the opportunity here. I will share about innovation, infection, prevention, and control, minimizing healthcare associated infection during crisis. Background, healthcare association infection, HIS, remain a major global health challenge, increasing morbidity, mortality, healthcare costs, and antimicrobial resistance (AMR) during pandemic, natural disaster, and other health crises. The risk of SIS rise significantly due to disruption in healthcare. Next. Okay, thank you. Service and limited resource. Innovative technologies such as AI, the Internet of Medical Things, telemedicine, and electronic surveillance can strengthen infection prevention and control practice. Therefore, integrating technological innovation with strong leadership, patient safety culture, and interpersonal collaboration is essential for building resilient healthcare system. The urgency of infection prevention and control IPC in the global era. Number one, globalization has increased the mobility of people, goods, and services between countries on an unprecedented scale. Asian international travel has enabled the spread of infection disease to occur much more rapidly than in previous decades. What initially appeared to be a local outbreak and developed into a global pandemic in a matter of weeks. For climate change contributes to emergency of new infection disease, rising global temperature, changing rainfall pattern, urbanization, deforestation, and environment degradation affect the distribution of disease factors such as mosquitoes, rats, and other animal reservoirs. This condition increases the rise of zoonosis disease transmitted from animal to human. As antimicrobial resistance, AMR, is also a serious threat. Irrational use antibiotic lead to the emergency of bacteria that are resistant to virus antibiotic. Patients experiencing STIs caused by resistant bacteria require more complex therapy, the more expensive, and have a greater risk of death. In this context, IPC is a key strategy for breaking the chain in infection transmission before it occurs. Prevention is always more effective, safer, and more economical than post-infection treatment. The relationship between IPC and patient safety. Number one, reduce the risk across infection. Number two, reducing the index of STIs, reducing patient mortality. Number four, improving the quality of healthcare service. Number five, reducing necessary antibiotic use. The last, reducing healthcare costs. Last, why is IPC innovation too necessary in time of crisis? A crisis is a situation that tests the resilience of healthcare system. During crisis, healthcare facilities often face various challenges, including sudden surge in patient number, shortage of healthcare workers due to illness or fatigue, limited PPE and medical equipment, disruption in the logistics supply chain, limited isolation room, rapid change to service guideline, increased risk of nosocomial infection, high level of physiology stress among vital workers. In these circumstances, sufficient efficiency approaches are often inadequate. Innovation needed to enable service to continue operating safely with limited resources. And this innovation includes a digital of infection surveillance system, use of artificial intelligence for early outbreak detection, automated disinfection robot, telemedicine to reduce direct contact, real-time IPC compliant monitoring dashboard, online training, medical learning for healthcare workers, cloud-based electronic reporting system. This innovation enable faster decision-making, increase results in efficiency, and strengthen the preparedness at healthcare facilities. Next. The role of interprofessional collaboration. The success of IBC cannot be achieved by one professional alone. Infection prevention requires a collaboration between various disciplines, including physician, nurse, midwives, pharmacists, laboratory analysts, epidemiologists, clinical microbiology, sanitation worker, hospital management, and policy maker. In the professional collaboration level, better collaboration in identifying infection risk, evidence-based decision making, effective communication, rapid response to outbreak, improved attitude to IBC protocol. In Indonesia, this approach aligns with the One Health concept, which is an incontinence of human, animal, and environment health. Facing the threat of emerging infection disease, cross-sector collaboration and increasingly crucial for building a resilient and adaptive health system. Types of healthcare associated infection. Number one, catheter associated urinary and tract infection is a urinary tract infection that occurs due to a prolonged use of urinary catheter. Catheters can serve a pathway for bacteria to enter the bladder. Risk factors: prolonged catheter insertion, non-aseptic insertion technique, open drainage system, poor burial hygiene. Prevention: use a catheter only when indicated. Use aseptic technique during insertion. Maintain a closed drain system. Remove the catheter as soon as possible if no longer needed. Cervical infection. NSSI is an infection of the cervical sac that can occur with 30 days of surgery of up to 90 days insertion procedure involving implant. Risk factor: cervical duration, diabetes mellitus, obesity, inadequate sterile technique, intraoperative hypothermia. Prevention: appropriate antibiotic prophylaxis, proper skin preparation, aseptic technique during surgery, glucose and body temperature control. Gastrointestinal infection, including to caused by Clostridium diphtheria, and often associated with the use of broad-spectrum antibiotic and can cause severe diarrhea and colitis. Ventilator-associated phenomenon is phenomena that develop in patient and mechanical ventilation for 48 hours or more. Central line-associated bloodstream infection. Leadership play integral role in the successful implementation of infection prevention and control by integrating evidence-based politics, allocating adequate resources, and fostering a strong patient safety culture. Effective leader must make timely decisions based on surveillance and epidemiological data, particularly during outbreak and health emergency. At the national level, government should strengthen regulation and standard IPC guidelines in line with WHO recommendation to ensure consistent implementation across health facilities. Strengthen data-driven surveillance program. Our surveillance is the IVC program without a robust surveillance system. Increase in infection rates are often detected late. Increase in the risk outbreak in hospital. During a crisis, surveillance must be conducted in real time using digital technology so that data on infection incident can be promptly analyzed. PD use informed decision making. Modern surveillance program include monitoring HIS, early detection of outbreak, monitoring hand hygiene compliance, monitoring antibiotic use, surveillance and of antibiotic resistant bacteria, dashboard-based electronic reporting. Strengthen human resource capacity. Healthcare workers are a key component in the success of IVC. However, during its crisis, they are also the most vulnerable group to disease exposure, physical exhaustion, and psychological stress. Training should not only focus on technical skill, but also encompass risk communication, risk management, proper use of PPE, occupational safety, and the management of patients with infection disease. Current training models are evolving toward more flexible approaches such as learning, microlearning, clinical stimulation, virtual reality, case-based learning, and the finish, outbreak simulation. Nah, optimizing the available of facilities, infrastructure, and logistic. Many future and implementing if IVC during a crisis are cost or resource limitation, such as a lack of PPE, disinfectant, isolation room, and sterilization equipment. Therefore, hospital must have a resilient logistic management system, including logistic need planning, electronic stock monitoring, efficient distribution system, provision of emergency logistic reserves, diversification. In addition to logistic, hospital infrastructure design must also support IPC implementation. For example, negative pressure isolation room, adequate ventilation, easily accessible hand washing facilities, patient flow that minimize cross contact, a safe medical waste management system. Utility of technological innovation IVC. Technological development have opened up significant opportunity to increase the effectiveness of IVC program. Digitalization enable faster, more accurate, and more efficient and effective surveillance. Strengthen patient safety culture. The success of IBC depends not only on procedure but also on organization culture. Patient safety culture reflects the value, belief, and behavior of all healthcare professionals and ensuring patient safety. Internet of medical things. Digital sense can be used to monitor hand hygiene, compliance, measure air quality, monitor the temperature of vaccine strong room, monitor the use of PPE. Example, disinfectant robot, telemedicine, digital IPC dashboard. Strengthening and interprofessional collaboration. Doctor, nurses, midwives, pharmacists, clinical microbiologists, epidemiologists, laboratory staff, environment sanitation worker, hospital management, and government. strengthening the antimicrobial tuberculosis IMS program. Antimicrobial resistance is one of the biggest challenges in IBC. Enough provided antibiotic use led to an increase and multi-resistant bacteria that are difficult to treat. The IMS program aims to ensure rational antibiotic use, reduce unnecessary antibiotic use, suppress bacterial resistance, improve therapeutic efficacy, strengthen emergency preparedness. Every healthcare facility must have an emergency preparedness plan that specialty can for if IBC component on the plan should include biological risk mapping, outbreak response procedure, emergency communication, disaster simulation training, business continuity plan, post-event evaluation. Regular simulation training is essential to ensure that healthcare workers understand their role in crisis situation. Summary, effective infection prevention and control IBC. During crisis requires strong leadership, robust surveillance, skilled healthcare workers, inadequate resource, and integrated emergency preparedness, digital innovation such as AI, the Internet of Medical Things, telemedicine, and electronic surveillance significantly enhance the efficiency and effectiveness of infection prevention by combining technology with a strong patient safety culture, interprofessional collaboration, and strategies and healthcare system, and become more resilient, adaptive, and capable of delivering safe, high quality care during future health emergencies. So, closing statement, innovation in infection prevention and control do not merely about adopting new technologies. It is about building resilient healthcare system where every patient, every healthcare worker, and every community remain protected, even in the face of future crisis. Thank you.
Yep. Okay. Thank you. This is Vivi Utami, PhD, for our second speaker. So that's why that globalization and climate change, it can be the impact. And strong leadership has important role to counter the crisis. Technology, internet can strengthen infection prevention. Okay, well, all of the participants, here I come to the time for you, for participants. If you have question, please, time for discussion. Anyone who has question, you may directly open your microphone and to speak up. Come on. But first, you can introduce yourself, guys, if you have question. Okay, please.
Apa medun Mas Raison jempal
Okay, we have
Digoleki ibu nang kono, digoleki bapak nang kono, lha kok nunggu.
Okay, we have the participant, Muhammad Hidayat. Yeah, okay. Please open your microphone and then you can continue to give question to our speaker. Please, time for you.
Excuse me. Many hospitals have advanced technology such as artificial intelligence, electronic surveillance system, and error detection robot. However, healthcare association infection rates remain high in some healthcare facilities. In your opinion, is the root cause of this issue not the lack of technology, but rather a weak patient safety culture and poor compliance with fundamental infection prevention and control, practice among healthcare workers, how hospital prioritize their investments between advanced technology and organizational culture and behavioral then to achieve sustainable improvement in.
Okay, thank you for your question. So it's about what is the role of the technology, especially in facing the crisis and also to strengthen the collaboration. So I give time for the speaker. This is Bibi Utami to give question.
Thank you for your insightful question, Saudara Hidayat. I agree for technology alone is not the primary solution unless it is supported by a strong patient safety culture. AI, electronic surveillance system, and disinfectant robot are valuable tool. But they only enable of effective infection prevention and control (IPC). Ultimately, the success of IPC depends on the people who use these technologies. According to the World Health Organization, core component in infection prevention and control program. The key determinant successful IPC implementation strong leadership, robust patient safety culture, continuous education and training for healthcare workers, and ongoing monitoring and evaluation. Technological innovation and significantly enhance IPC performance, but only when there's fundamental components are already in place. For example, a hospital may implementation a electronic surveillance system capable of detecting potential outbreak in real time. However, is healthcare worker continue to develop for hand hygiene, improve use personal protective equipment, or fail to follow assist at technique during invasive procedure such as catheter insertion. Healthcare association infection rate unlikely of decline. In other words, technology can identify problem more quickly, but it cannot replace safe clinical practice or change human behavior. Therefore, hospitals should prioritize their investment strategy. First, they should strengthen the IVC by fostering strong patient safety culture, improving healthcare worker commitment through continued education and training, promoting community leadership, and ensuring consistent IVC practices such as hand hygiene, appropriate PPE use, and aseptic technique. One this foundation as well as established hospital can integrate integrated advanced technology such as AI, the Internet of Media Things, electronic surveillance system, and digital dashboard to improve efficiency, support data-driven decision making, and enable early outbreak detection. In this context, investment in technology should never replace investment in people. In this, both should complement each other. Hospitals that successfully reduce HIs rate are not necessarily those with the most advanced technologies, but these have cultivated a strong patient safety culture, community leadership, high compliance with IPC standard, and effective use of technology to support evidence-based practice. In conclusion, if resources are limited, I would prioritize strengthen organization culture and comply with fundamental IPC practice before investing heavily in advanced technologies. Technology and delivery of optimize infection prevention effort, but fasting reduce in healthcare association infection depend primarily on human welfare, leadership, communication, and a sustainable culture of patient safety. Thank you, Saudara Hidayat.
Okay, thank you for Mrs. Vivi. That actually technology, especially like AI, can help to identify, but remember that human is still the main role in using technology. So, anyone has the next question? Okay. Yeah. Okay. Thank you. Enough for the second session for the speaker today. Thank you for Mrs. Vivi Utami, PhD, for lovely presentation. And now, please, let's make documentation. Yep. Okay. Yeah. Yep. Thank you. And now we will give the certificate to our second speaker today, Mrs. Vivi Utami, PhD. Okay, ladies and gentlemen, all of the participants, our international seminar today. Next, we have our last speaker, Sirilu Winichayotin, PhD from Faculty of Nursing, Mahidol University, Thailand. So here we can see the curriculum vitae of Mrs. Sirilu Winichayotin, that she was doctoral of philosophy in Medical University, Kaohsiung, Taiwan. And for her daily activity as the lecturer in Clinical Instructor Department of Fundamental Nursing. And also she has the interesting research, especially the quality life of the elderly. Okay, guys, ladies and gentlemen, please welcome our last speaker in our seminar today, Mrs. Sirilu Winichayotin, PhD from Faculty of Nursing, Mahidol University, with the topic Advancing Interprofessional Healthcare in Infectious Disease Preparedness for Community Dwelling Older Adult. Time for you, please.
Good morning, everyone. Good
Yeah.
morning from Thailand.
Good morning. Here in Indonesia is 10 o'clock a.m. Is it the same in Thailand?
Yeah, it's the same. Yeah. So I'm very glad to be here today and very thankful that you inviting me. Let me share my presentation.
Yes, please.
Have you seen my screen?
Just a moment, we don't see your slide.
Oh, I have to. Oh, I need to share first. Have you seen like this, my presentation?
Not yet. No, sorry, we don't see. Okay, wait. Yep. Okay. Yes, we can see your slide. Yes, please. You
Yeah.
can present.
Okay. Okay, today my topic is the advancing interprofessional healthcare against infectious disease outbreaks, strengthening interprofessional care for community dwelling older adults. Lesson from Thailand. At the beginning, I get the invitation letter and they say like beyond the outbreak, something like that. So I thought that what is beyond the outbreak? For my, I think it's right now we have passed the big outbreak, right? Like a COVID-19 before. So I thought that beyond the outbreaks maybe like a prevention and I would like to share like the lesson from Thailand to share with you guys. Today is not like a lecture, you know. I mean, not like that one way. I will share and you can respond and share your idea, your opinion. Maybe this from Thailand, maybe the same or different from the Indonesia. Oh. Let me start at the key idea of whole talk and the outbreak. The outbreak is never only about the infection. For older adult, I scope 5 things happen at the same time. The first is the infection risk. Older adult may get more severe illness, right? Because they frail, they prone rather than another age. But look at another is the interrupt care. After we have the outbreak or they have severe illness, the routine will interrupt. Routine care will stop. And also the social isolation growth. I mean, like maybe they need to stay at home or reduce contact to their friend, their family, or their society. Another physical function declines because when they have severe illness, they have the isolation and also they have to stop moving, like a limited moving. And family carry heavy the caregiving burden because after they cannot assist themselves, the burden will become from a family. So the family needs the guidance and the support. What we focus on the topic today, I will focus on the 4 things. Older adult living at home in the community. I want to like to share that in Thailand, older adult, most of them stay at home or community. Some of them stay in the institution or residential home or a nursing home. Most of them stay at the community and most activities away at home. And it's how interprofessional care connect because when they stay at home, we also have the interprofessional take care them at home, and many different professional they work on their role. And also the Thailand real experience I want to share with you later. And the last of the future preparedness, how to strengthen care before the next outbreak. Let me share together, and you can share with me also. The next, before anything, I want to start at the person-centered care remain essential during the outbreak because how to say, when older adults stay at home, right? We will have home visit, and that means we take care like person by person. It's also match the concept at the person care center. It's include daily routines like mobility, meal, sleep, social roles. We also take care of them like this. Is when the outbreak, we also take care of them at the same. And also the chronic condition. Most of older adults have the chronic disease, right? Like diabetes, hypertension, heart diseases, and moreover, we still take care of the family because the family need take care as well because they have a lot of burden, maybe stress, maybe depression, or maybe feel like a tired when they take care of their family. And also the functional goal, like we have to concern about independence, dignity, and participation of the older adult or of patient during the outbreak as well. Another important thing, I thought that we need a social needs to connect to people, trust, and belonging. For the key for this slide, I would like to highlight that our care goal is to protect life while preserving function, dignity, and the connection. For this slide, show that how an outbreak can create a cascade of the problem for older adults. When an outbreak begins, let you see, older people are often advised to stay at home. This may be necessary for infected prevention, but it can also reduce the daily movement like this. An outbreak stay at home and reduce mobility. When they move less, the muscle strength and physical function may begin decline. And they also miss the clinic appointments at the hospital because of the transportation. They have limited of the movement. Any service are disrupt or they are afraid of becoming infected. After they miss appointment at the hospital, right, then lead to the medication problems. It's like prescription may not be refilled. They cannot take a continually medication. The medication that they use in daily not refilled, and chronic conditions such as hypertension, diabetes, heart disease become unstable. For at the same time, after they stay at home, they miss the appointment from the hospital is the health condition, right? In another, in the social condition, they will stay alone because they need to separate. And Another, they feel loneliness because they reduce the contact from the family, friends, and the community in the daily life or as usual daily living. These problems do not occur separately. They not reinforce one another and may eventually lead to the frailty and dependency or hospitalization. An important point is that an older adult does not need to be infected to experience this decline, but the disruption caused by the outbreak itself can harm health and functional ability as well. So, prevention alone is not enough. We must to maintain mobility, medication, social connection, and access to care. So that means the important thing, continuity care is also important in the outbreak. Continue from the previous slide, we can saw that the outbreak can create the cascades of problems like a reduced mobility, missed appointment, medication interruption, loneliness, right, and functional decline. So look at this one. When we have the concept like a person-centered care, older adults may need support for infection, monitoring chronic disease, right? Another is the physical function, medication, mental health, and also the society like a family or their communities, including the referral as well. That means we cannot take care older adult alone. I mean, one healthcare professional cannot take care older adult alone. So we need the other collaborate with each other. Like nurse, pharmacy, laboratory, midwifery, and also like public health, family, volunteer, and the community need to collaborate for caring of older adults. And as I mentioned earlier, that we need to have the collaborate of another professional, right? Now I would like to share in Thailand, the connection working in Thailand. I thought that the outbreak that the biggest in Thailand that we have experience is like a COVID-19. So maybe I will give you an example about COVID-19 in Thailand, and also we can share like the role of an interprofessional at the community and take care of older adults. When Thailand respond to the COVID-19 outbreak, it was not only hospital-based because at that time, the hospital is not enough to admit the patient. So the community need to have an important role to support this this patient that has infected from the COVID-19. So I think that Thailand we have a major strength that the community-based care, because we can connect to the household primary care service, family, and local community. Like the first one, the primary care team, we also have that, and I think that in Indonesia you have like this as well. And we have the primary care team. They will provide the first line access, like assess the risk, support the chronic disease. And another, we have when they have something change, the primary healthcare will screen as the first line. They will have make decision like a referral or still can control at home. The second one is we have village health volunteer. Village health volunteer breathing the household and service, because they will like the bridge between the healthcare provider and people in the community. And another is a family caregivers will provide daily support. And also community participation and trust. In public health, guidance is more effective when people trust the person delivering the message. We can trust them that they deliver information to the healthcare profession. We can trust that it's true, it's not false. And finally is a referral system. It's also important because the community care for the community care is not intended to replace hospital. Its role was identify risk, early provide appropriate support at home, and escalated care when necessary. So that I will show that we not respond only in the hospital base when we have an outbreak. Is another I want to deeply show the village health volunteer is the bridge because it's a community primary care and public health system. The village health volunteer is help in the healthcare system a lot in the community because they can screening, they can also provide the health education, also do the home follow-up, communication with the people in the community, and referral support. And important thing, we can trust them that when they deliver the information when the crisis. Anyway, I want to tell you that we have the village health volunteer before the outbreak, before the crisis. So they may have more workload when we have the outbreak last time. When we compare the between Thailand and Indonesia, we have like the village health volunteer, or in Thailand we call as osomo. And when we compare like cadre in Indonesia, because this slide I also discussed with my friend from Indonesia that we have the same or different like the healthcare system. So in Thailand, we have a sub-district health promotion hospital. So that means other people that stay at the community may not go to the tertiary hospital first. We can screening in the sub-district health promotion hospital first. It may be compared to Indonesia like Puskesmas. If apologize if my pronoun is wrong. And another elderly club or community group maybe can compare to Indonesia like post Jandu Lansia. And another is we have the healthcare system is we use the UC or universal coverage scheme, and Indonesia you use JKN, yeah. And I thought that we quite have the similar culture because we are Southeast Asia, right? And I thought that strong family caregiving culture is might be the same, similar, yeah. So I thought that is the you can more understand in the Thailand community-based care system, yeah. And another I want to share that primary care and community follow-up is which they can connect between home and the hospital. Like at home, they will have they do the daily observation, family and volunteer, they work together. And then go to the primary care, they will do the assessment, chronic care follow-up. And another, if they cannot handle, they will refer to the hospital because there's a hospital, we have the many specialist care refer, like they have some severe or red flag, they will refer to the hospital. This means the primary care help decide who can be safely monitored at home and who need the referral. Home isolation and community isolation during the COVID-19 outbreak. We in Thailand expand use for home isolation and community isolation because some of them no symptoms or only my illness, not the severe. So home isolation made quite popular at that time. First, at the first, healthcare professional assess whether the person was clinical stable when they stay at home, right? They will check the environment at home is safe for isolation or not. The second one, the patient received the continuing contact through the telehealth or other communication that they appropriate at the convenient, because right, in the community lower level may not have the smartphone, they have only like a analog mobile phone. It's so difficult when we contact with them, and maybe they have like a low income, so it's difficult to use a video call at that time. But right now we develop, most of people may have the smartphone, even the low level in the society, yeah. And then the care team support, the medication support, they provide a guidance, the symptoms depend on their program that they get. Patient might also receive basic monitoring equipment and other necessary supply. But then the system needs the clear referral pathway. If have something happen or severe, like breathlessness, low oxygen saturation or confusion, they will refer. This time is the beginning of the telehealth, and because of face-to-face was limited at that time. And this is the case example from the community isolation. This is as I mentioned before, if they have something happen, they will have the care box. They can get the follow-up by the user telehealth, and they can receive the medication when they consult with the pharmacies via the telehealth or via online. And I thought that like a seamless transfer if there's something happen or the how to say the have the severe illness, they will refer to the medical team at the hospital. This is a case answer in Friday. I try to give you an example. You can look at it later. And this is a Thailand framework, because when we take care people in the community in every age, we will have the key framework, three things framework, like one is food, the second is mood, and another is exercise. But in Thailand, we call TO. This is a Thai alphabet. TO is like it had the same vowel. It's like อาหาร is food, อารมณ์ is mood, and ออกกำลังกาย is exercise. So that's why we call TO. Okay. I just would like to share that. Maybe in Indonesia you have the framework take care of people like the health promotion framework like this for easily um, uh, remember that one. Okay, we also the food we also promote them like if they lost appetite or maintain staying with family guidance how to provide food for them, including they have problem about the swallow as well. And another is mood. We will monitor like stress and also the depression, and another which even both the family and patient. And another is exercise, is help older adult to prevent the deconditioning with the C stage like stretching, and we can promote them like mobility exercise. And when we take care of older adult, that we know that older adult is more frail when we compare with another age. So we not only check them about the health, we also need more assessment for older adult. Like important thing is a frailty or dependency, because why we need to promote them like do functional daily living as much as they can, right? And the next I will show the role of nursing when the for the case and at home. The nurse will do the holistic assessment, health education, care coordinator, symptom monitoring, mental health support, and healthy aging promotion. It's not even the nurse we can work alone. We also need to work with another healthcare professional like a pharmacist, because pharmacist will know about the medication, the side effect, drug reconcile, and maybe they have the drug allergy as well. And also need to aware about the vaccine, because older adult also need the vaccine as well for prevent another disease. And laboratory, we need them to help us about the early detection, the testing accuracy, the specimen management, and surveillance data and timely report. Even the laboratory is back behind the scene, right? But it shape the team to the next step. Is very important as well. And another role of the midwifery and family health. When the outbreak or we also have the pregnancy and women at home, right? Maybe they take care about maternal child, community care, do the family counseling, household prevention, vaccination, communication, and community education. And this is the integrated care pathway for older adults during the outbreak. For another part, let me let about 5 minutes. Okay. For another, we also have older adults in the community, and also some of them we still have them in the institution, like a residential home or nursing home. We still have them. If like this, when the outbreak, they will have model like a safe bubble. It's like they do like a zero visitor policy that can reduce external exposure during high risk period. So no one can enter, no one cannot enter in the institution. And another is the bubble and seal protocol, and they limit movement between zone. Like maybe the institution is big area, right? They will limit zone. If you stay at this zone A, you will stay at only zone A, cannot cross from to another zone. And task shifting, as we know, like external specialists cannot enter. So yeah, the staff at work in the institution will need to monitor. If they have red flag, they will have to stop working. And another is bridging the psychosocial gap. Stick isolation protect from the infection, but may increase delirium and depression and loneliness. Be careful, because that means isolation should not never mean abandonment. And another that we need to concern, like community palliative care during the peak outbreak. I want to say that even if the outbreak, the palliative care is still necessary. The needy must remain care goal when hospital access is limited. Also, the palliative care should be in the community as well. Like provide them the peace, the comfort, and the dignity for the patient. And this is my last presentation, like a takeaway strategy for the interprofessional teams. The first one is task shifting, empowerment family members and communities volunteers with simple tools and training. They are valuable healthcare extenders. And the second one is accessible technology. In Thailand, most application that we use to contact, we use Line, or in Indonesia, you use WhatsApp, right? When you need to contact. This one is the good way to connect with the patient. And holistic focus, treat the person, not just the infection. Actively support movement, nutrition, mood, and social connection. We need to take care them with the whole how to say in the whole in the I mean that in the every section in their life. And this is, I will share you like the 5 lessons from Thailand. The first one is the community trust matter. And the second one, family are part of care team. The third one, volunteer extend the healthcare system. The fourth one is the interprofessional communication saves time. And the last, healthy aging must continue during the outbreak. Need to preparedness starts before the next outbreak as well. Maybe we can adapt in Indonesia like a map, the map who already reached older adult at home. Maybe you also have, right? And another agree on simple escalation criteria. choose one everyday technology as this clear responsibility for the medication continuity and keep food, mood, and movement in very home care plan. Okay. Thank you for your attention. This is finish my first presentation.
Okay, thank you, Mrs. Cyril, for your presentation. So that we can say that outbreak can affect the system, yeah, not only infection
Yeah.
rates, yeah.
Yeah,
So
I share.
yeah, remember that person-centered care remain essential during the outbreak, and especially for older adults needs require connected roles. So from your presentation, we can see that in Thailand, strengthen community-based care, not only hospital care, yeah. So not only from hospital. So we need the community, and we can see that actually we have similar between Indonesia and Thailand. You can say in the Indonesian pronunciation is puskesmas, yeah, or pos,
Puskesmas,
yeah, puskesmas, and also kader posyandu. So it is in Indonesian pronunciation, yeah. Okay, please for the participants, I will give you time to give question. If you have, you may raise your hand or and then speak up. I will give you one or two participants to give question to our speaker today, Mrs. Sirilu Winichayotin. Please. Oh, okay. From the room, we can see that we have Shirley Patricia. Okay, please, you may open your microphone and directly to speak to give question to the speaker.
Okay, thank you, Mr. as a moderator. Can you hear me? Okay.
Yeah.
Good morning, Miss Siriluk. Okay. I really like your presentations and insightful. And by the way, you look so beautiful. I really like it. Yeah. So I have one question for you. Telehealth as an important right for maintaining continuum of care during outbreaks. And however, many studies suggest the community healthcare outcomes are often driven more by the public trust, local leadership, and interprofessional collaboration than by technology itself. So, in your opinion, should future healthcare investment focus primarily on digital transformations, or should greater priority be given to strengthening social capital and building a culture of collaboration within communities? Thank you.
You asked me about technology, right? In the future, right?
Yes.
That I clarify you. Yeah, it's a good question, and for the real life, it's quite difficult. So I thought that we can, that I mentioned before, that we can use the daily technology. Yeah, like in Thailand we use Line, in Indonesia we use WhatsApp, right? I'm not sure that another technology is meant for people in the community or for everyone is what is that if in the real life. If when we study, we can try everything, like we can do the telehealth, we can do like a video call, because we do the study, we can provide any material for our participants. And for the trust, I thought that for the trust, when I share for you for the trust, that we know each other. That's why we can trust everything that they transfer to us. But for other and for if we need to the next beginning, and if we thought that we need to start from zero and learn with each other. Yeah. Thank you.
Okay, thank you. So, Shirley, do you get insight from the answer from Mrs. Sirilu? It's enough, yeah? Okay. Okay, well, once more, if you still have a question from the participant, anyone? So I think that community is very important role, especially when we face the outbreak, like when a few years ago we have the pandemic like COVID-19. So I think the support of the family, the community, it has important role to make the people can healthy faster than before, yeah. Okay, well, ladies and gentlemen, because no one will give question again, so I will say once more, thank you very much for Mrs. Sirilu Winechayatin, PhD, University, for the interesting presentation. So the last, we will make documentation, please, before closing this statement from Mrs. Sirilu. Let's make documentation. Yeah, okay. And now we will continue by giving certificate to our speaker today, Mrs. Sirilu Winechayatin, PhD. Okay, once more, thank you very much for Mrs. Sirilu Winechayatin for your time, for your sharing your expertise, and I hope that someday we can have a meeting again, we can discuss and share about the knowledge. Thank you very much for Mrs. Sirilu Winechayatin.
Thank you.
Okay, see you next time and keep healthy. Okay, well, ladies and gentlemen, for all of the participants today, start from the speaker 1, speaker 2, and the last speaker, we can say that from this seminar, we can have insight, we can have knowledge, and I hope that we can collaborate for the next time. In the name of the committee from the STIKES Rajekwesi Bojonegoro to celebrate 32nd Idias Natalis, I also thank you very much for all the participants and also the speaker. Well, ladies and gentlemen, it's the end of our seminar today. Once more, I hope that for next time we can join and also we can have the collaboration for the next agenda. I apologize for mistake during connecting as the moderator, and I will give back to our master ceremony. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much to our speaker for the great presentation and to Mr. Ari for the moderating the session. And then the materials shared today were very interesting and easy to follow. It gave us new ideas, motivation to keep learning and improving in the field of health. We can really appreciate the time and knowledge shared. Once again, please give our speakers and moderator a warm virtual applause. Now, before officially close the morning session and head to lunch break, we would like to invite all participant speakers and committee members to switch on your camera for a group photo session. Our technical team will take the screenshot. Please give your best smile and hold it for a few seconds. Technical team, are you ready to documentation? Okay. Slide 1, the first is 3, 2, 1. Okay, and then the second slide. 3, 2, 1. And then next. 3, 2, 1. And then the fourth slide. 3, 2, 1. Okay, and then the fifth slide. 3, 2, 1. Now, before we head to the lunch break, we have an exciting announcement. We are going to announce the 3 winners who will receive e-money, the prize 50,000, which the first congratulations for one is Alia Revidia, and then the 2 Muhammad Hidayat, and the 3 Shirley Patricia. And then for all the winners, please kindly contact our commit right away via the Zoom chat box or the contact person. Provide, don't forget to send your full name and an active phone number and your e-money wallet details so we can process your prize. On behalf of the entire organization team, I'm Tiara Aulia. Extend my deep gratitude to all speakers, participants, and technical staff who worked tirelessly to make this international seminar a success. May the knowledge insights shared here today inspire further collaboration and innovation in healthcare on global scale. Thank you, and we look forward to welcoming you again at your next event. Wassalamualaikum warahmatullahi wabarakatuh.